nursing has specialties for a reason, and emergency nursing is a specialty. Med-surg nursing is a specialty, and I think we can't stand up tall enough screaming to the rooftops. These patients deserve specialists taking care of them. And emergency nurses are not those specialists. We're good at a lot of things. We shouldn't have to be good at taking care of admitted patients.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement, because we all know emergency nurses have the best stories. Now here's your host, Kevin McFarland.
Hey everybody, Kevin McFarland here, and welcome back to the Art of Emergency Nursing. As always, I'd like to thank you for listening to the show and remind you that if you ever want to get in touch with me, you can reach out to me on either Facebook or Instagram. Both those platforms are great ways to reach out and get in touch with me with any questions or comments about the show. This week, I have a great episode with a longtime ER nurse, a nursing educator, a speaker, and an author. You are going to love this episode with my friend, Andi.
Thank you. My name is Andi Foley. I'm the clinical nurse specialist for St. Luke's Health System for their emergency services, emergency departments. Basically, that's in Boise, Idaho. And basically what that means is that I do practice design for emergency departments. I support 4 what I'll call regular emergency departments, 4 critical access, 1 standalone, and 1 urgent care. And that's kind of the scope of my work. I am blessed to work with an education specialist who has ED in her whole background as well. And the 2 of us are blessed to work with a EPIC person. That's our electronic health record. And so the 3 of us get to work together on all of the great problems that emergency nurses face. And then we all get to work with unit-based educators and hospital-based educators as well. A little bit about my background. I was an EMT, and I got my EMT through the service. I was a medic in the Army and got to work at a hospital-based ambulance service where I got to see what emergency nurses did day in and day out, and I was hooked from there. Graduated from school, couldn't get a job in an ED because that was one of those periods in our history where there were more nurses than there were nursing jobs, and was absolutely just so fortunate to get a job in a 10-bed ICU CCU. Really got to learn basics and really got to learn like the basic patho and stuff like that. And I was there for a little over a year when a job opened up in the emergency department where I had done my senior school practicum experience. Jumped right into the ED, and I've been there ever since. ED at heart.
That's awesome.
Yeah.
So never did floor, never did med-surg?
I have done 3 shifts of med-surg because I got floated from the ICU. And that's it.
Wow, that's you're now you're 3 times ahead of me, but now, and here's a question I have for you, because one of the things I wonder, and I know that for me, I started in the emergency department straight away. But what I found is that in today's day, where a lot of times we're sitting on admitted patients and sitting on them for days, I find that I'm not as strong a nurse as some of my people who have been, med-surg in the past, or were SAC in the past, where they, the MARS and all that, kind of skin assessment and all that stuff that they have to do. They really got that down. And I find that I'm like, maybe I'm not as good at that, but boy, you give me a recess or a trauma and I gotcha.
Well, and I think that it's a little bit different. Somebody who is entering emergency nursing now is, whether we like it or not, those newer nurses are getting med-surg training in the ED. I'm not saying it's great training,
Yeah.
But they're getting more experience with those patients that are boarding in the ED than perhaps you or I ever did as we were coming up in emergency nursing.
That's a really good point, is that they're certainly far ahead experience-wise for inpatient than I was when I was taking care of. For me, when I first started as an ER nurse, it was unusual to take care of admit patients for very long, and now it's every day.
In some places it absolutely is. And like, nursing has specialties for a reason, and emergency nursing is a specialty. Med-surg nursing is a specialty, and I think we can't stand up tall enough screaming to the rooftops. These patients deserve specialists taking care of them. And emergency nurses are not those specialists. We're good at a lot of things. We shouldn't have to be good at taking care of admitted patients.
Absolutely.
Patients deserve
No,
better.
it's not our wheelhouse. Yeah. That becomes especially important when you talk about behavioral health patients. And behavioral health patients, I think, and oftentimes ER nurses are very well versed at taking care of these patients, but they're certainly not our normal. Yeah, that's not what we're good at. We don't do as good a job as they would be if they were being taken care of in a behavioral health unit.
Exactly.
Like a true behavioral
and
health
it's
unit.
not for our behavioral health patients. It's not just the nursing specialty. It's also the environment. The chaos of an ED is just not therapeutic to what they need to stabilize and get better.
Absolutely right. And I remember we had a patient who was in the emergency department for, probably 4 or 5 days waiting to be transferred to behavioral health. Our hospital didn't have behavioral health. And, it was one of those that about 3 days in, one of the docs finally called psychiatry and said, "Hey, can you give me some ideas on like what daily meds we should maybe get this lady started on? Because she's decompensating every day, almost by the clock. Is it right around 4 o'clock and right around, 2 in the morning, she would just start to kind of decompensate. And it's one of those, well, of course she is. She hasn't been on her psych meds for a week.
Yeah. And that's on an adult patient. Now add in our pediatric patients, and while they may not be on some sort of medication regimen, their needs are so different, and their resources are even slimmer than the paltry things that we have for adults.
Absolutely right. You're so right. Peds psych is, boy, talk about, getting some anxiety, and ER nurses all over the world right now talking about holding a peds psych patient. I'm sure they're like, oh my gosh. So what made you decide to go into nursing?
Again, it was just seeing those ED nurses when I was an EMT working on the rig, and just from stubbed toes to sepsis, heart attacks to, healthy baby checks. They could do it all, and I wanted to do that.
That's cool. At what point in your career were you sure you made the right choice?
It was probably pretty early on. I was still in the ICU, CCU at the time, and one of the things was, yes, you had to have ACLS, but they also put you through a little mega code, and I was so nervous because they said, you won't know when it's coming, you'll just show up one day and we'll do this mega code. And I went in and did it. I'm not saying that I nailed it or anything, but felt like I know what I'm doing. I can answer these questions. I can take care of these patients. And then
what a great feeling.
Too long after that, I had a patient who had a swan in, and the physician was very, very particular about the care, and they had me go in with the physician and did fairly well. He didn't scream at me at any point, and this was, 20 years ago.
It's a plus.
When that was more common than it is now.
Not uncommon.
And I came out, and my partner that I was working with that day said, you handled that really well. You were so smooth. You were so calm. And it was just, yep, I can do this. I can take care of sick patients and kind of keep it smooth, keep it calm.
Good for you. That's awesome. What a great feeling. I remember those old mega code days, and those were usually like, it was one of those where no matter what you do, your patient's going to die. So just it's not you, it's us. But do you remember when ACLS was like I always say that ACLS now is much kinder and gentler than it ever was when I started. When I started, it was like, you're going to get a mega code, the patient's going to die, and we're going to put you through every rhythm on the way down. Mm-hmm. You're like,
we're going to try and be sneaky and tricksy, and you've got to pay attention to every single little detail all on your own when we know we practice as a team.
Yep. It's like, no, we're going to have this artificial environment where it's all you making all the decisions all by yourself.
Which, I mean, in fairness, we still do that in TNCC and ENPC. And the way that I personally rationalize that is because we've all been with that person in a code who just freezes. And by making us do it ourselves, it makes us more ready to not be the person who freezes.
Yeah. So tell me a little bit about your transition when you went from being at the bedside to being in clinical education.
Oh my gosh. When I went to nursing school, so I got my associate's degree and then I got my bachelor's degree, and most of the way through my bachelor's degree I was going, I think I want to teach. I think I want to go into nursing education. And at the time I was thinking I would love to be faculty and then also have like a part-time gig as a nurse practitioner, right? So when I was going through my bachelor's degree, that was kind of where my brain was at. I got about halfway through my master's in nursing education and said, I don't know if I want to be a nurse practitioner, but wow, staff development. So being that unit-based educator or that hospital-based clinical educator, yes, that's where I want to be. I want to support new nurses. I want to help with the the enrichment sort of education. And I applied a couple of different times before I finally did get a position. And the position that I ended up getting was centralized. So I reported up through the hospital education structure, but then I had dotted line responsibilities to the emergency department. And that was the biggest emergency department I'd ever worked in. It was an 84-bed ED, and that's not counting any of the hallway spaces. And there were almost half as many hall spaces at that time. It was crazy. And then supporting all of the nurses that it takes and all of the techs that it takes to support an ED of that size. And
holy cow, that's a big ED.
And they had good leadership structure. They had team leaders and supervisors, and like in terms of helping with the regulatory stuff and the auditing things that often fall on the educator. So my job was really heavy in onboarding and then some of the more regulatory stuff in addition to other duties as assigned that always happens. And I had a great mentor who said, Andi, a nurse educator has 3 buckets of work. You have the onboarding, you have the regulatory stuff, and you have the enrichment stuff. And you want to spend most of your time on enrichment because that's what the staff wants, but you're not going to be able to. And so fit it in when you can. And she said, you know the emergency setting, you know education, and now let's put them together. And she was just amazing.
What great advice for a unit-based educator. And that's probably the best, most concise way to describe the unit-based educator role that I think I've ever heard. I mean, you're going to have to do everything. Mm-hmm. And what the staff wants isn't necessarily going to be what you're going to be able to do all the time. But I think you just nailed it. Holy cow.
Thank you. Denise Haynes.
That. it's, I just took a role probably very similar to yours, and it's, my first education, like full-time education position role, and I'm super excited about it. But I just keep realizing, boy, there's just so much to do.
Congratulations, and yes, there is. The good news is there will always be more people who need to be trained up and more things to train them on.
It's a good point. There will certainly always be work, won't there?
There will always be work. And then the nice thing is the difference between the nursing educator role that I had and the clinical nurse specialist role that I have now is that I'm really looking at evidence-based practice translation. So how do we get the best care to the bedside? How do we prepare for what I call next practice, right? Once we're doing best practice, then there's next practice. And how do we prepare the team for that in an evidence-based way? So that's a little bit different from what I was doing as an educator. I don't do a whole lot of education. I don't do any onboarding anymore. That's completely up to the unit-based educators. And now I get to support them as they say, hey, Andi, why do we do this? Or why don't we do this? Or I just went to a conference and I saw this great thing or concept or whatever, and should we be doing that here? And I get to dig into the literature and go look at the workflows and go, well, yeah, we should be, or, well, no, but here's why. Really helping the staff understand the why behind their practice.
That's exactly, so the role I took on is called professional development. It's like professional development specialist. And that's exactly the way my boss described it is you're not doing the unit-based education stuff. You're doing the system-based. As a system, is this something we should do? As a system, how can we help them do their jobs better?
You're gonna
as a
love
system.
It. You're gonna love it.
I'm super excited. I'm super excited about it. I'm intimidated that it's going to be. I know it's going to be tough, but I'm super excited for it. And listening to you just makes me even more excited. Yeah, and what's interesting enough is I've always done education. I've always done education part-time, but this is the first time I'm taking it on as my full-time job. So
see, maybe we'll bring you over into the CNS realm.
It's a possibility. They don't, the only system that's really adopted CNSs as well as anyone else has been the VA, but it's not quite as like this system doesn't use CNSs, but this professional development specialist is kind of the thought process behind that. I think
it sounds like a very similar thing.
Yeah, for sure. So, but anyways, I'm excited for it, and you're making me more excited because I want to be like you when I grow up. So
that's very generous of you.
Anyways, so let's talk a little bit about some of the patients you've taken care of and a little bit about your history. Tell me about a patient that changed the way you practice.
Changed the way I practice. Fairly early on, my very first emergency department, I remember taking, and I don't even remember what the meds were, but I took this handful of medications into the patient, and I had this was long before the days of barcode scanning and things like that, and so I had put them into the cup like my nursing instructors, like my preceptors taught me, and took them in there, and he said, "What are those? I don't believe you." And and the thing that changed my practice was after that day, I always opened packages of medications in front of the patient. So if they wanted to see what it was before I opened the package, I could show them.
Interesting. That's a good way to do it, especially probably more important now that you have barcode scanning, you kind of have to do it at the bedside almost.
Well, you do and you don't. There are certain medications that you don't necessarily take the nitro to the bedside. You don't necessarily take the insulin to the bedside, right? So there are some of those multi-dose vials that we still have for good for good nursing workflow reasons created a workflow that you don't take the initial vial to the bedside.
Yeah, that's true. That's true for some of the multi-dose stuff. Yeah.
But you're right. For the rest of it, technology has kind of forced us to take the packaging to the bedside, whereas we didn't always before.
And can you imagine there's still a lot of systems that don't use barcode scanning?
It just blows my mind. And the reason that it blows my mind is because with all of the meaningful use work, I thought everybody was on EHR. No, some people are still on paper and making that transition now. It just surprised me.
Yeah, I think I haven't seen too many that aren't on EHR. One of the things I do typically see, I've seen a couple times is their trauma and recess documentation being paper. Yes. Just because they haven't convinced the nurses that electronic could be faster. But typically you see them on EHR, but what I still don't see in all the places I've been is I still don't see a lot of people doing barcode scanning. They're just pulling from the Pyxis and going and giving the meds.
And some of that probably has to do ultimately with the cost of the equipment. I know when we switched to the EHR, we went with barcode med scanning, but we didn't go with patient signature stuff in the rooms. And our med-surg team saw an almost immediate drop in the discharge instructions metrics for stroke and heart failure and those sorts of things because the papers got lost. Well, if we would have, paid the money for the patient signature equipment, then those metrics wouldn't have been a problem. If we would have paid the money up front for barcode med admin, then patient safety is just one step closer to foolproof. Not foolproof, but one step closer.
Yeah. As an educator now, what has your attention right now?
What has my attention right now? So I get to kind of come in on the beginnings of a lot of things. And so as a clinical nurse specialist, what's got my attention is how do we screen our patients for the risk of violence, and what's the tool to use? Because I've done a lot of looking, and I'm not finding tools that are validated in the emergency department. And so then the question is, do we trial it in the ED and see how it goes, or do we wait until somebody does the research and then translate it? Another something that's kind of caught my eye just recently is another screening tool for intoxication. And it goes along with an assessment that the providers would do, and the two of them together are designed to look at behavior specific to intoxication, as opposed to saying, let's hold this patient until their alcohol level is low enough, pick whatever your X is. And, of course, by that time, they're heavy into withdrawals, and then we're admitting them because they're in withdrawal, but for no other reason.
Yeah, other than, we've been doing nothing with them for the last, 24 to 48 hours.
Exactly. And so those are two of the things that I'm sort of looking at and working on right now. Like what is the best practice? What is the right thing for our system? Because when you're making a decision for a system, it has to be the right thing for all of the hospitals. I've got critical access and not critical access and freestanding. So what's the right thing?
what do you think? Besides the obvious differences between all the different systems that you work for or that you serve, besides the obvious things like staffing and resources, what do you think is the biggest difference between the difference between your critical access hospitals versus your larger centers? Like how do you think, do you think the staffing is different, or the staff that are there different? What are your, besides just, the numbers and resources, what do you think are some of the other differences that people might see or appreciate?
My critical access teams are, every team I work with is amazing. The critical access teams are kind of unique because 2 of the 4 are in resort towns. The other 2, one of them is military, and one of them is kind of just right at that 25-mile mark from a trauma center. And so close, but just far enough away to still meet that critical access. And really it's, how do you make sure that decisions that are coming from what I'm going to call the mothership meets those needs? Well, but we don't have pharmacy 24/7, and the nursing supervisor or the charge nurse is doing that work. And so how do we make sure that that work can be done safely away from all of the resources, in a hospital where everybody is wearing 3 or 4 different hats?
I don't know if you heard the recent interview I did with Sarah Wells, where she was in Sweden and in the Netherlands, and she said, she goes, here's the funny thing is, wherever you go, a nurse is a nurse is a nurse. I mean, they're kind of doing the same thing.
Exactly.
And I was like, yeah, that's a good point. And certainly that's been my experience in going to national conferences and going all over the place. You find out that you're a lot more alike than you might think you are. Everyone's got the same problems. Monday sucks for everybody.
True.
We all have doctors that analyze and nickel and dime you to death. We all have our frequent flyers that we don't want to see every day, but there's always something. There's a lot that we have in common that makes us probably more alike than we are different.
Exactly. And going back to what I said earlier, emergency nursing is a specialty, right? So within
Absolutely
that
right.
specialty, we are more alike than we are different.
Absolutely
but then
right.
Take it to our med-surg colleagues or our critical care colleagues, and their specialty is so different, even though a cardiac assessment is still a cardiac assessment. But the way that we put those pieces together is different. I was just thinking, because we know the main difference between emergency nursing and pretty much everything else is working with a diagnosis versus working with a differential. And a differential diagnosis is kind of like having a child's puzzle where only half the pieces are upright and you don't know what the picture is. I think I've got an idea of what the picture is, but these pieces aren't fitting together. And what's this weird one? Versus almost every other specialty gets to have all the pieces upright and know what the picture is supposed to look like at the end.
Yeah, exactly. So, it's funny how, again, care is care, and we're all kind of doing the same thing, and we all kind of, we're just trying to meet the patient's needs within the best resources that we have available, is what I think almost all nurses are trying. And it just kind of comes down to, how much we can do. And again, within our specialty, that is emergency nursing. So
exactly.
So that's cool. So tell me about the first time you made a med error.
My first med error was in nursing school. I was in my last semester, and we were at a skilled nursing facility, and I was doing a med pass with my instructor, of all things, and had this patient who was alert but confused at baseline and known for refusing her meds. So I go to do this med pass, and she refuses, and we kind of do a little cajoling, and she finally agrees to take the multivitamin, but refuses everything else. And get back to give it to her, get back to the cart where you do all of the sign-offs with the med books and everything. And the primary nurse employee from the skilled nursing facility came around and said, "What, you gave her meds? She took your meds?" I had already given them, but hadn't been documented.
Oh, no.
So,
oh no.
So it was kind of an error on both sides. Well, okay, so she doubled up on her multivitamin, so not that big a deal.
Yeah. I mean, on the good bad scale, it's not terrible.
And in practice how you want to move forward, it taught me to do the best I possibly can about being timely with documentation.
Absolutely. How many times, I don't know how many times it's happened to me where I'm walking into a room with a syringe and someone's like, "Oh wait, already did that. Sorry, haven't charted yet."
Exactly.
And you're like, "Oh, you're killing me.
Close.
Come on."
So close, those near misses. Yeah.
Oh yeah. The near misses sometimes are, I think, better lessons than anything else, where you're like, that could have been bad. So,
yes. Yep.
So, yep, for sure. What's the best advice your mom ever gave you that you ended up taking to nursing?
I don't know that it was advice per se, but something that my mom modeled for me was when I was in middle school, my mom went back to school and really modeled lifelong learning. She helped edit most of my papers through grad school and through my doctoral degree, and so it wasn't so much advice as it was I saw her living that, and it made a big difference to me. And even when I talk to nurses who are going back to school or who are contemplating going back to school, and but I've got kids, and I share that example of one of the reasons that I'm so passionate about learning is because my mom really modeled that for me at a fairly young age. And so I just really think that that's a gift that we can give children, is seeing us as adults be really dedicated to education.
Absolutely. I think that it's one of those, there's never a good time to go back to school. And it's hard for everybody. You're like, I get it. Now, what made you decide that you wanted to go get your doctorate?
So I was looking at going back to formally get my degree as a clinical nurse specialist. And it was one of those things that, okay, well, it would be an extra year and then it's done. And so if I'm going to go for it, I may as well just go all the way, because at the time I was looking at programs that would be like a post-grad certificate or another degree or all the way to the terminal DNP, and I decided I may as well just go ahead and just do it while I'm kind of in the school mode.
Makes sense. If you're gonna go, just go.
And again, for that program, it was one more year, and so I'm like, okay, yep, I can do it for one more year.
What advice would you give somebody who's looking at taking on a doctoral program?
I would say, number one, you can do it. If you're even a little bit interested, then you already have the passion and the drive, and so go for it and do it. A lot of programs now are online or have some sort of distance learning online component to it, and so either make sure that you can do clinicals somewhere close to you, or start very, very early in making those contractual arrangements so that you can do clinicals close to you.
Oh my God, yeah. That's sometimes the hardest part. I have a friend who's finishing her FNP, and she's like, it's so hard to just get clinical spots.
Yep. Yeah, and
so I
know people who have traveled across the country to do their clinicals, and it ends up being an absolutely wonderful experience for them, but not everybody has those opportunities, either financially or family or those sorts of things. And so if you're thinking of doing an online program, look down the road at what else you're going to need.
Absolutely. I think, you're like, don't be surprised at the end where you're like, oh, clinicals? I got to do clinicals?
Exactly.
You're like, yeah.
And your clinicals have to have a contract. And sometimes it has to be, your program has to be approved by the state that you live in, by their board of nursing. So there's all of these loops that you might have to jump through.
Yeah, it's true. It's my friend who's finishing up her FNP. She's finishing up her FNP now, and she struggled to just find clinical relationships because so many places have students already, and so many people are going to school that it's hard to get in and find these places if you're not, in that state's home group of schools.
Exactly.
So, what are your thoughts on people going from, entry level to doctorate to master's to nurse practitioner to practitioner? So what are your thoughts on that?
I think that it's a slippery slope. I think that one of the challenges that nurse practitioners have in this day and age is the physician's claim, I did all of this education and you, nurse practitioner, did so much less. And the argument that I can make as a clinical nurse specialist, as an advanced practice nurse, is that's true. My formal education was less, but I have almost 15 years of clinical expertise to draw on as well before I got to that point. So
Absolutely.
for those nurses who are choosing the entry-level master's route, they can't make that same experiential claim. And sometimes they're making the physician's arguments for the physicians. Like, yeah, I only did 500 hours or 1,000 hours or whatever it was that their program had versus all of the years that you physician went through.
Yeah, that's true. I mean, it's certainly something that there definitely is a difference in experience, and somebody who goes from entry level goes from finishing their BSN to going directly into a nurse practitioner program, then your nurse who's got 15 years experience behind their back saying, I've seen all these clinical situations. I've taken care of these patients. Now I'm learning a little bit more and kind of opening up my idea of what that role is. But I still got that experience. So interesting. What's the best advice a mentor ever gave you?
The best advice from a mentor would be an amazing nursing supervisor that I got to work with in Florida. Her name is Babs. And she said, Andi, you have to ask for help. She said, I can tell when you're busy, but I can't tell the difference between busy and drowning. And sometimes it's just, I can give one med or I can start one IV. And that's the thing that helps you not be drowning anymore. She said, you have to learn to ask for help.
That's a good point. I mean, boy, how many times do you see that where you're like, you see someone and there's a difference between busy and surviving and busy and drowning.
But you can't tell it from the outside. until it's way too late.
With the good nurses, I think that's true. I think with good nurses, it's sometimes hard to tell that. If you're kind of a, maybe not as strong a nurse, it might be a little bit easier to tell. But for the strong nurses, yeah, it can be hard to tell when they're drowning versus when they're like, I'm good, I'm busy, but I'm good.
Yeah.
That's a big difference.
Sometimes it's just that one little thing. And I've worked with so many amazing teams where the productivity model has allowed for a float nurse, which is just a gift in those departments that are able to do that. And those floats can save your bacon, right? They are proactive
Absolutely.
and looking at doing that IV or giving those meds or getting a patient settled who just came in EMS.
Yeah, I mean, I used to love it when I get to be the float nurse, and they're like, just float around and help people. I'm like, sure.
Yep.
You're probably in a position where you get to give new nurses advice all the time. What's the best advice you give new nurses starting in your emergency departments for the very first time?
Ask questions. Definitely ask questions, because I think that as a new nurse is working with a preceptor, they don't know. And if you don't ask questions, then you're potentially playing a game by rules that you don't understand, right? So an example that I use is set yourself a goal. All right, patient comes back from the waiting room having gone through the triage process and they're roomed in the back. And you say, I want to get in to see a new patient from the waiting room in 20 minutes. And then you get in there in 15 and you're going, yes, I rock it out of the park. But your preceptor was thinking that you should get in 10. So your preceptor's thinking, I don't know if she's going to make it. Unless you ask those questions about what should my goals be? Where should I be at? Is this a normal expectation, or what's the expectation I should work towards? In addition to asking questions of, well, why would you do it that way? And I don't understand why we would do this treatment modality. Physician, can you help me understand? Just ask questions, because it's the nurses who are quiet, that don't ask a ton of questions, that the team can't get a good feel for, and then ultimately start saying, well, I don't know if he or she knows their stuff. I don't know if they're safe. I can't tell what they're thinking. And so that's my advice, is ask questions. A lot of questions about everything.
So oftentimes as an ER nurse, people will ask us, what's the worst thing you've ever seen in the emergency department? And of course, they don't really want to know the worst thing we've ever seen, but what they want is a good ER story. What's your go-to ER story?
So we had this patient, young lady, and she was well known to the department, but it was my first time interacting. And this is, again, back on paper charts, and her medical record had come up, and she was a multi-visit patient to the extent that she had more than one folder of medical records, right?
Yeah. Now, for the youngins that don't realize that, do you remember the days when they used to bring up the patient medical record in the folders? Holy cow! Like, I haven't heard that in a little while.
Yeah.
Like, I forgot about that until you mentioned it. Now I remember them coming back, and if the patient had more than one folder, then they were a frequent friend.
You knew that, but again, I had never taken care of her before. She probably had some element of maybe a Munchausen's sort of thing and some attention-seeking behavior, because the reason that she was a multi-visit patient was because she'd had so many surgeries because she'd swallowed stuff. Her favorites were paper clips and or batteries. And the day that I saw her, she had swallowed A and AA alkaline batteries. in her record,
Wow.
she had swallowed C-sized batteries.
That's dedication right there.
I didn't see anything in her record about like button batteries that we now know are so dangerous as well. But so I asked her, kind of just trying to be funny, have you ever swallowed a 9-volt battery? And she looked up at me and just straight-faced, and she said, I'm not stupid. Okay.
So it's going to hurt. How are you going to get that down?
I had to ask. But
that's a funny story.
But she's not stupid, and it's good to know.
That's funny. Boy, the self-injury is a topic I'm really, really into and really interested in. And boy, I've just never understood. I don't understand it. I don't pretend to understand it. But boy, I find it fascinating, the people that will hurt themselves and what they'll do to hurt themselves, and to get to go to surgery, to get hospitalized, to get whatever benefit they get out of that. It just blows my mind that people will go to the extremes that they do to fit whatever need that is. Now I don't even know what need that is, but I'm not gonna pretend I do. But it's crazy that the things people will do to themselves.
Yes, and again,
so
we have no idea what need that fills, and we just have to be as open-minded and empathetic as possible. Just take good care of them.
Switching gears a little bit.
So for our listeners, what was your role in the revision of Sheehy's?
So ENA had put out a call saying that they were looking for both contributors, and then there was a separate call for someone to edit the book, and they were looking for, well, they didn't say it at the time, but they ended up being interested in a team for editing. I had just finished some work with Jane McGrath on the McGraw-Hill CEN review book, where we co-edited that. And I thought, okay, well, I'll put my name in the hat. It can't hurt to at least try and see. And ended up being selected. So Vicki Sweet and I have edited the most recent edition of Sheehy's and got to work with some of the most amazing authors and contributors. There's a new chapter in there on ethics, a new chapter on workplace violence. We did some combinations of a lot of forensic type chapters and put them all together instead of having separate chapters, and then it still has the big buckets of medical type complaints, assessments, interventions, and then trauma-based injuries and assessments and interventions. And it was a lot of work, don't get me wrong, but just also a lot of fun and very rewarding in the end to be able to say that I had a part in continuing Sue Sheehy's work of having resources available for emergency nurses to help continue emergency nursing practice.
What a cool honor. Holy cow, that's cool.
Absolutely. And the previous editors, Patty Howard and Rebecca Steinman, just really left it in a nice place for Vicki and I to continue it moving forward. And again, just adding a couple of things that are more evident in our practice than they were with the previous edition.
Yeah, that's what an awesome opportunity to be able to do.
Absolutely.
Talk about leaving your mark on a profession. What a cool way to do that.
And again, I was in the right place at the right time, and I raised my hand and said, I'll try it. And so anybody who is interested in writing, do it. Submit to the journal, submit to your newsletter for your own chapter or state council ENA. Just get involved, and if it's something that you're even partially interested in, go for it, because it is, like you said, super rewarding.
I bet. Holy cow. That's on my bucket list. It's on my bucket list for 2020 is to try to see about getting something published. I don't know what that'll be, but get something published. That kind of brings us into the last question I always ask everybody is I always ask people for 3 things to remember and 3 things for an ER nurse to forget.
Okay. So 3 things to forget I'm going to start with.
Okay.
Forget about being the hero, right? You don't have to do everything for everybody. Ask for help. So forget about being the hero and ask for help when you need it. Forget about being the loner. And now what I mean by that is you don't have to be best friends with everybody at work, but when you build a relationship with your team, you get to know what's normal for your team, for behaviors and things like that. And when you know what's normal, you know what's abnormal. So you know when they've had some big significant event and they're starting to act differently. So the person that is the first one in the break room when there's donuts suddenly doesn't want any. Or the person who never goes in the break room when there's donuts suddenly is the first one in. Those changes in behavior, those normal responses to abnormal events, you can protect your team if you can recognize them, but you can't recognize them if you don't know them. So don't be forget about being a loner and get to know your team.
I like that.
And the last one I have in forget is forget about being done. You are done with school, and you may never go back to formal school again, but nurses are lifelong learners. In order to stay up with best practice and next practice and just good quality safe care, you've got to be a lifelong learner. And again, that doesn't mean you got to go back to school, but you got to be willing to continue learning. So forget about being done. 3 things to remember then. Remember to advocate. Advocate for yourself, for the things that you need. Advocate for your team. Advocate for your patient. It's something that nurses do super well, and just remember that that is an emergency nursing superpower, is advocating. Also remember that assessment isn't the end. You've got to have strong clinical skills, and you've got to be good at assessment. But if you don't know what to do with that assessment finding, or you don't know why it matters or doesn't matter, it doesn't do any good. So assessment isn't the end. You've got to do something about it. And last but not least, remember that if you don't take care of yourself, you can't take care of your patient. So what self-care looks like is different for every single person. And figure out what that looks like for you. Figure out what that looks like for you at work in terms of making sure that you get little mini breaks when you can, making sure that you advocate for yourself getting a lunch, make sure that you take care of yourself and have good shoes because you're on your feet for 12 hours. But then also take care of yourself at home in whatever way that means. However you find your joy, do more of that and take care of yourself.
Nice. What's your favorite thing to do to self-care? Like what's your self-care? How do you come home from a long busy day? What do you do to kind of unwind and relax and get back to you?
I have a wonderful pair of dogs who greet me and just are happy and, help me relax and unwind. And I also love to read. The thing that I do kind of on the way home, I am both fortunate and unfortunate that I lose cell service on the way home. So I am not calling and not basically interacting with my phone in any way, except that I've learned that I can listen to books on tape on my way home. And
nice. I love books on tape.
Between books on tape and, quite honestly, nerding out on podcasts, that's what I can do on my way home that helps me unplug as well.
Nice. That is great advice right there.
Whatever you got to do.
That's good
advice. Find the thing that brings you joy.
That's, it's kind of funny. I used to work in a place where I had about an hour commute, hour to hour and 15-minute commute each day, or each way. So, double that per day. Boy, I got really caught up on my podcast, and then I got a job that was like 20 minutes away, and I was like, oh man, I don't have time to listen to all these podcasts I listen to now.
I know, right?
Well, I can't thank you enough for spending the time talking to me. I really, really appreciate it.
It has been my honor and also quite a pleasure. Thank you.
Absolutely, for me too.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.